Next is a short case presentation by Dr. Shafsina and Dr. Ampli on the topic cleft lip and cleft palate. The internal examiner is going to be Dr. Shamshad Beegum, professor and HOD at MES Medical College, and the external examiner is Dr. Anil Kumar, professor at JSS Medical College, Mysore.
Good evening, all. It seems all of you have tired after hearing a torch of subjects from the morning onwards. Okay, so we are reaching towards the end of the day. So my topic is today, we are discussing about a case of cleft lip and palate for surgery. That's a common case is kept for all the examinations as short case. So all the PG students should go through this, as well as you have to study it very thoroughly, because once it is get to do it, it will be very difficult when you go through it, because we have to take adequate care. So we will try to reduce this, finish it within 20 minutes itself. Okay, my students are Dr. Shafsina as well as Dr. Anjalisha. Ambilisha. Okay.
Coming on to history, informant's mother, my child is a 10-month-old male child presented with history of nasal regurgitation while feeding, recurrent respiratory infections and ear infections since birth. No associated congenital anomalies. Past history, frequent episodes of respiratory tract infections managed with antibiotics, nebulizations, no ICU admission, unilateral left cleft lip correction surgery done at 3 months of age, and obstetric and birth history, antenatal history is uneventful, and natal history, full term, lower segment cesarean section, birth weight 2.8 kg, cried immediately after birth, visible defect of left upper lip noticed by the pediatrician at birth. Developmental history, no developmental delay. Dietary history, exclusively breastfed for 6 months. Difficulty in sucking and nasal regurgitation of milk noticed since birth, so the baby was fed with Palate. Immunization history, fully immunized to date. Family history, no history of cleft lip or palate in the family. On examination, general examination, the child is active, alert and febrile, and weight is 8 kg. And the vitals are normal. On airway examination, left unilateral cleft of soft and hard palate, approximately 2 centimeters seen in roof of oral cavity, surgical scar of left cleft lip correction present. Systemic examination, all systems were within normal limits. Investigation, blood group is O positive, HB 10.9 gram percentage, total counts 9,100, coagulation normal, and echo done at the time of birth is normal study. Summary, 10-month-old term male baby of current weight 8 kg with past history of cleft lip, correction surgery done at 3 months of age, presented with nasal regurgitation, recurrent respiratory and ear infection since birth. On examination, diagnosed with left unilateral complete cleft palate and posted for palatoplasty.
Thank you. So now there is a twist. If they don't answer, I will ask somebody in the audience, students, to answer. Because they are new to me. And we had only one meeting. I didn't tell what I am going to ask. Even I am not prepared what to ask. Just we'll start with this. Madam is courteous enough to give all chances to external examiner. This is a 10-month-old baby weighing 8 kg. Is that weight appropriate for this age? What is the formula that is calculated? If you don't know, don't get demoralized. That is how in exam some question suddenly randomly will jump and you will be, you need to face it. Is it appropriate or no? We can't waste time. Already 4 minutes over.
18 months plus 9 by 2.
Very good. Then?
According to that,
Calculate and tell.
10 plus 9, 19 by 2. No, it is not appropriate for the age.
Okay. So, what is the problem? What was the problem? Though
It
the
is
patient
inadequate weight.
Very good. Then you are told, you asked a negative history of the upper respiratory tract infection. What is the relevance for this case?
In cleft palate patients, there is difficulty in swallowing and resulting in recurrent nasal regurgitation and causing the recurrent respiratory infections.
So,
The child is more prone for respiratory infections, and this is a risk factor for while posting the child for an elective surgery.
suppose the child has come with an active respiratory tract infection. What will you do? And surgeon is insisting, no, I need to do, I am going international trip next couple of days. He's insisting you, he is forcing you. And you have examined that patient is having active infection.
If the child is having active respiratory tract infections, then it is better to postpone the surgery.
Not better, you must postpone for
the
how long?
surgery for 4 to 6 weeks. Minimum of 3 weeks is recommended.
So remember, it is always an elective surgery, it is not an urgency. All cleft or elective surgeries. Good. Now, you said you will postpone at least for 3 weeks of an antibiotic therapy. Then the other point is, you also said an important negative history as no congenital anomalies observed. What is the relevance for this case?
Almost more than 300 congenital anomalies are associated with cleft palate, namely Peary-Robin syndrome, Treacher-Collins syndrome, Klippel-Feil syndrome, Down syndrome, Nager syndrome, Van der
Stop
Woody
here.
syndrome, etc.
Suppose they given a choice for you, though this baby is normal, like a hypothetical situation, a Peary-Robin is there and the Treacher-Collins is there. Which you would like to intubate? Which you would like to choose the case for airway management?
In the case of Peary-Robin syndrome, as the age advances, the intubation becomes easier. Whereas in Treacher-Collins syndrome, as the age advances, the intubation becomes more difficult.
Very good. And what is the mechanism? Can you tell in Peary-Robin, it is changed to Peary-Robin sequence rather than a syndrome?
In a Peary-Robin sequence, the initiating event is the mandibular hypoplasia. So the tongue is placed higher up in the palate, resulting in defective closure of the palatine shelves. So this is what happens, and sometimes it may be due to mechanical obstruction, like in oligohydramnios, it can develop, and also it can be due to abnormalities of the temporomandibular joint.
Mainly it is a hypoplasia of mandible which is causing all these problems. Okay. Next, coming to how you work up this case now. Now the case is there, and we'll come back to our real scenario, the particular case, and how will you go about this case?
First, we have already done a thorough clinical examination, thorough clinical history, as well as examination
Very
of the
good. Now,
child.
what is your lab workup?
So I'll do a blood grouping, cross-matching, serology will be done, and
Kindly tell what is the relevance, why you want blood grouping for a palatal surgery?
Since palatoplasty is a major surgery, there is increased chance of bleeding. And
Done. What is the importance of hemoglobin?
Hemoglobin, since the child is having recurrent episodes of the poor feeding, there will be increased chance of nutritional deficiencies as well as anemia. Since there is increased chance of bleeding as well, we need to know the hemoglobin, and if more than 10% of the estimated blood...
Stop. Don't dig your grave in exams. See, you're not giving one more opportunity to ask a question. So when particular question is asked, you innocently answer and stop it. So your next answer will be probably the examiner's next question. Okay, what is the importance of counts?
For cleft lip and palatal surgeries, the total count should be less than 10,000.
It goes with what rule? Rule of 10?
Killer's rule of 10. The total count should be less than 10,000.
For cleft lip you are talking, or cleft palate?
For both cleft lip and cleft palate surgeries, the total count should be less than 10,000 per cubic millimeter.
Only that?
No, the hemoglobin should be less than at least 10 gram percentage, and for cleft lip surgery, the weight of the child should be at least 10 pounds, that is 4.5 kg.
Pounds.
And for cleft palate surgery, the weight of the child should be at least 10 kg. And above the age of the child, for cleft lip surgery, it should be at least 10 weeks. And for cleft palate surgery, it should be at least 10 months.
Why this 10 weeks and 10 months? Appropriately, maybe in second month or third month? Or why this particular age grouping?
For cleft lip surgery, at least of 10 weeks is preferable, because for the anatomical and physiological maturation of the baby, and as well as since the cleft lip and palate is associated with more than many congenital cardiac defects.
No. Talk only about cleft lip first. Why that particular As early as possible.
As early as possible, because cleft lip, there is defective suckling and swallowing in cleft lip. For to improve the feeding of the baby, the cleft lip surgery has to be done first, and 10 weeks is preferred for initial evaluation of cardiac defects as well as anatomical and physiological maturation. And for cleft palate surgeries, early surgery will result in growth palate scarring as well as retardation of the maxillary as well as mandibular development. So preferably 9 to 18 months of age of time is preferable for cleft palate.
Before the child starts phonating.
Yes.
Okay. Now you know the appropriate age when to do. Now, what are the airway difficulties you generally encounter in a case with cleft palate?
In cleft palate,
First you tell together with cleft lip and cleft palate. Assume that patient is having a bilateral cleft lip and palate or a unilateral complete cleft lip and palate.
So
What are your airway difficulties?
in complete cleft lip and palate, initially we have difficulty during mass ventilation because of the escape of air, and during laryngoscopy also we will feel difficulty because of the left-sided cleft palate. There is trauma to the palate because of from the flange of the laryngoscope. Difficult intubation is anticipated, and also if it is associated with other congenital anomalies such as Pierre-Robin syndrome or Treacher-Collins syndrome, where difficult airways anticipated. Physiological difficult airways anticipated.
Then anything else? So whenever the airway is talked about, all the 5 components should finish. Difficulty in mass ventilation,
laryngoscopy and intubation.
Insertion of laryngeal or the supraglottic airway devices, and passing a tube as well as extubation. All the 5 components should be there whenever the difficult airway is asked about. Is extubation difficult here? You expect a difficult extubation or not?
Yes, we are expecting
What is the difficulty in extubation?
Because cleft palate surgery, it is associated with more chance for airway edema. That is, edema of the tongue uvula occurs, and also because after palatal surgery there is reduction in the size of the oral cavity, that also prone for airway obstruction. There is chance for rebleeding, retention of the clot secretions, and causing post-operative bronchospasm. Because of this because of the intubation, there can be post-operative laryngospasm can be there, retained packs.
It is because of intubation or something else? You said because of intubation there can be chances of laryngospasm.
Edema.
As said, they will have some amount of airway inflammation. Second, added by the surgical trauma as well as the presence of an endotracheal tube. So what law, physical law it goes with? That even a 1 mm of airway edema can increase the airway resistance by? What is the physical law?
R raised to 4, inversely proportional
What is
to
that?
the law of lap.
Okay, now somebody told. Then how will you work up? Now how will you pre-medicate this kit? Assuming your OT is ready, your OT temperature is ready, only 7 minutes left, and all your airway equipments are ready. Assuming that, how will you pre-medicate? Will you pre-medicate? Yes?
Yes,
No.
for this child, in this child we are not expecting associated with any airway congenital anomalies, and according to the institution protocol, we will pre-medicate the child from the preoperative area. Before that, I will reassess the NPO status of the child. I will reassure that the chest is clear and check for the patency of the IV cannula, and antibiotics will be given 30 minutes prior to the procedure, and I will pre-medicate the child with.
Are you not ensuring something else? Very important thing.
NPO status.
Very good.
NPO status of the child is reassured.
Can you tell me the nil by mouth status that has to be advocated in these kits?
According, our institutional protocol is that we will advise the mother regarding the NPO guidelines is fasting of solid foods, including formula feeds and cow's milk for 6 hours, and breast milk for 4 hours, and clear fluids for 2 hours.
So suppose mother says, can I make my child drink a glass of water, a bottle of water? How will you advise?
Oral fluids has to be given by 3 ml per kg per hour.
Max.
So according to the weight, we will advise. In this child, we will give around 25 to 30 ml.
Of water. Okay. Then, Nilbimo status is checked, antibiotic prophylaxis started, then
IV
IV cannula, you
access.
check the patents for IV cannula. Suppose IV cannula is not there.
So if the IV cannula is not there, I will
Our
prefer,
sister says, I'm not able to put, she is requesting you to insert in the operating room.
I will pre-medicate the child with IM ketamine 2 to 4 mg per kg, and once the child is sedated, I will shift the child to the OT.
Do you know how much time it takes for the child to get
15
sedated
minutes.
with-
15 minutes prior to the shifting.
Have you given any time? And alone ketamine you're giving intramuscular?
Along with midazolam can be given at
No,
0.25.
not can be given.
Midazolam is given 0.25 mg per kg.
Okay, assume that your IV cannula is working now.
Because our institution protocol
Yeah,
is
yeah,
we
no,
will
yeah.
be putting the IV cannula in.
We respect all the protocols.
So if the IV cannula is present, I will pre-medicate the child with IV glycopyrrolate 0.01 mg per kg, IV midazolam 0.05 mg per kg, and IV ketamine 0.5 mg per
You're
kg.
giving this in pre-operative holding area.
Pre-operative area, and with oxygen support and SpO2 monitoring, and looking for the chest movements, I will shift the child to the OT. Once the child is inside the OT, I will ask the assistant to connect the 5-lead ECG, pulse oximetry, non-invasive BP, and post-induction we will place the ETCO2 and temperature monitoring. Along with that, I will pre-oxygenate the child with 100% oxygen, and I am planning for IV induction. So I will give IV propofol 2 mg per kg to the child, and once the child is apneic, I will check for the adequacy of back ventilation by the JR circuit, and I am planning to give the neuromuscular blocking agent as IV succinyl
What kind of endotracheal tube you're choosing for this case?
Ring Adair Elvin tube, south pole of size
And
3.5.
your store fellow tells it is not available, the appropriate size which is required for your kid.
And micro cuff tubes can be used.
Very costly. Patient is a schemed
Flexometallic
case.
tubes. Flexometallic tubes can be
Okay, suppose it is also not there.
normal tubes.
Normal endotracheal tubes.
Because why? It will not make a much difference because the slit of the, what is the apparatus the surgeon uses?
Dingman's
Dingman's
retractor.
retractor.
Dingman's retractor has got a slit.
Slit in the
It doesn't make any actual difference, whatever the tube you use, but ideal tube should be, what is the advantage of the tube? You said some RAE. What is the tube? What
It
is
is
the
a
full,
Ring
preformed tube.
Preformed
full
bend.
form of RAE?
Ring Adair Elvin tube. There will be a preformed
What are
bend.
the advantages and disadvantages of the tube?
One is it has got a preformed bend. It can be kept in, since we are positioning the tube at the midline without distorting the anatomy of the lip, it can be easily placed. Second is, the tube will be away from the ventilating circuit so that it will not.
What is the disadvantage?
Kinging of tube
obstruction
can
of the tube.
Still it is occurring, then what is the use? One, the
the
suctioning
fixed
is an
length of
issue
the
and it
preformed
doesn't
bend.
suit for all the built of a particular age. It can be outside because if you see the bend, it is at the junction of 1/3 and 2/3. It may not fit for
For all person.
particular age for all the growth. Okay. Then what are the other historical tubes, if you know? Can you name them, which were used for this particular surgery?
In earlier days, Oxford tubes were used.
And Cole's tube. Okay, now your child, you have done successfully, very well, no bleeding. What was your fluid?
Ringer, balance of solution, preferably ringer lactate, according to the Holiday Saga formula.
Very good. So that is done. So no much blood loss and everything is done. And how will you extubate this case now?
Once the surgery is over, I will do a thorough oral examination and will assure that there is no airway edema, including edema of the tongue due to the pressure of the Dingman's retractor and uvula, and there is no fresh bleeding, and I will remove the throat pack. If there is edema, I will go for an elective ventilation post-surgery. If there is no edema and no fresh bleeding, I will give reversal.
How will you ensure there is no bleeding? You cannot see. You need to do
A
laryngoscopy.
will be done, and
But while doing laryngoscopy, what care you take? Because it's a palatal repair. Even a small mistake, so you will be giving away the sutures. And unfortunately, surgeon doesn't allow, and even we are scared to put both nasopharyngeal, oropharyngeal airway because again it can affect these are the challenges at extubation. This case. Assume that you have extubated well. Now post-operatively patient is restless. What are the causes for that?
Post-operatively, there can be airway edema and obstruction.
Very
because
good. So
after
most of the time, it may be related to airway, rule out that. Ruling out airway problem.
then,
Could be due to pain.
Very good. It may be pain. So you need to adequately, how will you treat pain, post-operative pain?
Intraoperatively, we'll give fentanyl, opioid, 10 microgram.
Just name it. We have got only 30 seconds.
Okay, fentanyl will be given, and paracetamol suppository 30 mg per
Very
kg will
good.
be given, and intraoperatively local infiltration can
Very
be
good.
given, and certain blocks, the infraorbital, suprazygomatic,
Wherever
maxillary
possible, all
nerves.
use regional blockade. Now, after ruling out pain, what are the other causes for
rebleeding,
restlessness?
rebleeding, retained secretions,
No, restlessness. Airway is removed.
emergence delirium can occur.
Very good. Apart from then, you have not used sevoflurane, you did it with Tiva.
Because of the prolonged action of the anesthetics and opioids.
Parental anxiety, that is more important. So separation anxiety. So many a times when you get the patient to mother labs, that will be get treated. Thank you very much. You have cleared. You have cleared your exams.
Thank you, doctors.
Frankly, it was a very random questions we fired. Even I was not prepared.
Now, I request Dr. Anil Kumar to distribute the participating certificates to Dr. Shamshina and Dr. Ampli. Now, I request Dr. Rajesh to please come onto the stage to felicitate Dr. Anil Kumar. I also request Dr. Balabhaskar to come onto the stage to felicitate Dr. Shamshad.
Thank you, Akka Mahadevi Madam, as well as the Department of Anesthesiology of Mupans Medical College for giving us a chance to participate in this, and also the ISA Wayanad City branch. Okay, thank you very much.